Okay, we're ready. Go. Good evening, everybody, and welcome to our Marcus Alert Community Town Hall, and it's going to be the first of probably several in the future. This is a really exciting evening. We have a whole team of people to help us with this presentation. You'll be hearing from Anita Friedman, who is the Director of Human Services and my boss. We have Lieutenant Steve Troiano, one of the team of ACPD staff who've been working closely with us on this initiative. And we also have a technical team behind the scenes helping us with this presentation this evening. And I really want to give a shout out to Caitlin Hutchinson, who did an incredible amount of work, has been supporting the Marcus Alert initiative. Kurt Larrick, our communications officer, who is providing some backbone support and will manage our questions this evening. And Michael Dharma Irwin and Brian Vickers, who are supporting the technical aspects of tonight's presentation. So we have a lot to cover, but before we go forward, I do want to share with you, we have an option for submitting your questions through the chat. And if you're not familiar with the chat feature, you go to the top part of your screen and there's a little bubble there. It says show conversation. You click on that and you can write your questions in there. We will pause at various moments in the conversation and respond to a few clarifying questions. Any questions that we don't respond to, we will write up our responses and post them on our webpage. I failed to introduce myself. I'm Deborah Warren. I'm the Deputy Director of Human Services and the Community Services Board Executive Director for Arlington. And again, welcome this evening. We are here to introduce you to the Marcus David Peters Act, the Marcus Alert and what that means and what that's going to entail. We're introducing you also to the Department of Human Services, which is a major player in the crisis continuum of care, and the Community Services Board services, which support ensuring that individuals receive the care that they need when they need it. So we will look at our existing crisis services. We'll look at opportunities. We'll look at what's coming down the pike in the next 6 months. And we will talk about opportunities for future evolution of our crisis care continuum, and then talk about our next steps. And you'll have an opportunity to vote on those opportunities. Next slide. So this entire initiative, statewide initiative, is focused in on racial equity. Why? Because the research shows, and there was a study that was published in the BU University, Boston University Law Review that showed that an unarmed Black man is more than three times as likely to be shot in the process of having a behavioral health crisis. Marcus David Peters was a 24-year-old biology teacher, graduate of VCU, working at a high school, and he was commuting home from work one day in May of 2018, having a really severe behavioral health crisis. He got into a car accident. He pulled over on the side of 95, and he emerged from his vehicle. A police officer saw him and approached him. He was hit by a car. He still approached the police officer, was tasered, and was shot and killed. And the entire interaction was only 76 seconds. This tragic event led his family, just galvanized his family, and they advocated successfully for legislation to improve behavioral health services and ensure a behavioral health response versus a law enforcement response to people in crisis. And that led to legislation in 2020 in a special session, General Assembly session, focused in on racial justice amid many protests that were going on at that time in Virginia and nationally following the death of George Floyd. The legislation that was actually that was successfully passed is pretty complex and it has multiple layers to it. We'll try to highlight some of those tonight as we go through. The Marcus Alert, actually, it's using Marcus David's name, and Marcus stands for Mental Health Awareness and Community Understanding Services, or Marcus Alert. And the idea is that all across the state, there'll be a way that people can call in, someone to call to, have some sort of mobile crisis, someone to go to them, and a place to go to when they're in crisis to get the help that they need. So we're really in luck here in Arlington because of the foundational work of our police practices group that completed its work in February of 2021. And a lot of the work that's been done at the county and at the county level in response to those recommendations. But let me introduce you to some of the aspects of the Marcus David Peters Act. Next slide, please. Okay, so one of the pieces of this that drills down to the localities where we really have the emergency call centers, our emergency response and local law enforcement and local community services boards. We must, each locality must complete put together a stakeholder group and develop a local plan. And that's where you as a community come in. We need to have everybody's input as to how we should change our system to ensure that everybody gets the help that they need, when they need it, where they need it. Next slide. So we will be putting together all of this input and putting together a local plan, developing a local plan with our stakeholder group, which I'll introduce you to shortly, and submitting that plan by the end of May of this year. It's a very compressed timeline, so it's a lot of work on the part of the stakeholder group and in collaboration with the staff. So just wanted to really emphasize the piece about racial equity. I already gave you some data about disproportionate impact and intersection adverse outcomes with during a behavioral health crisis with BIPOC individuals. And a real emphasis of this act is to focus in on racial bias, to ensure that we have culturally competent crisis care, and to ensure that Black and minority individuals have equitable access to behavioral health resources. To that end, the state has Equity at Intercept Zero initiative, and that includes multiple levels, one of which is the development of a Black-led coalition that will actually oversee the Marcus Alert development across the state and provide input into its implementation. Also, the state is really working to engage small private providers, particularly Black-led organizations that can be looped into the existing crisis response to ensure that that individuals get to work with persons that look like them, and really developing more peer-led, that is, persons with lived experience organizations. So there'll be there'll be a public-private partnership, if you will, using MOUs to strengthen the crisis system of care. Next slide. I'm going to turn it over now to my colleague, Anita Friedman, who is the Director of Human Services, to share the work going on at the county level.
Good evening, everyone, and thank you for tuning in to this very special town hall. We really appreciate your participation. I'm Anita Friedman. I'm the Director of the Department of Human Services. And as Deborah mentioned, we really have a focus of the Marcus David Peters Act and the Marcus Alert on racial equity, because we know that in the area of behavioral health, there is a disproportionate negative impact on people of color. I wanted to bring to your attention some of the work that has been done both in the county and in our Department of Human Services. But let me start with the county. You may know that in 2019, the county adopted a county equity resolution, which put front and center the work of racial equity as a mission for the county to achieve. And as a result of that, the county manager, Mark Schwartz, appointed Samia Bird, who was then a deputy county manager, to be the chief race and equity officer for the county. And she created then a racial equity core team, which basically has representatives from all county departments and from the Arlington Public Schools. And we developed a countywide racial equity framework. Then in about August of 2020, we conducted various staff trainings, workshops, listening sessions, and dialogues, and we had specific racial equity dialogues with Challenging Racism, which is a local group, with community members so that we could broaden the understanding of the community of privilege, bias, and equity, and what that means and how it shows up in Arlington. There's also some very interesting tools that are also available online, including a race and ethnicity data dashboard, which is a tool to obtain data on racial disparities across many domains that can be used for policy decisions and program design. And we also have a racial history timeline, which is continuing to be built out, that documents the history of racial discrimination and racism in Arlington. So these are really valuable tools for all of us to be informed about the history of racism in Arlington and the prevailing disparities that exist in our county. And those are all available online at the Arlington website. Next slide. So if you don't know about our Department of Human Services, well, we are one of the largest departments in Arlington County, and we serve about 50,000 clients, and probably, you know, at least a quarter of Arlington's population, if not more. And we work with all kinds of services that provide people who are vulnerable, at risk of adverse events, living in poverty, living with severe mental illness or substance use disorder, living with a disability, with services basically from birth until death. We have 145 programs across 5 service divisions. We're an integrated department, and we were created that way in the 1960s. So folks back then even thought, well, in a place like Arlington, which is relatively small geographically, but dense in terms of population, we should have a one-stop shop, which is what we have at our physical location of Sequoia Plaza, where we operate in 5 principal domains. Services for aging and disability, which means people who are over 65 and aging in place, or people who are living their life with a developmental disability and need different kinds of supports. We work in behavioral health care, where this Marcus David Peters Act basically lives, so to speak, because it involves behavioral health care, and we respond to crises 24/7. We work in child and family services, strengthening Arlington families very closely with Arlington Public Schools, supporting families for their needs for their children, from mental health to child care to child welfare. We work in economic independence. That's an area that revolves around providing financial stability for people who are in poverty. The average income of folks who come to that area of our department is about 30% of area median income. So we're working with households where $38,000 a year is the total income for a family of 4. So we're providing Medicaid and rental stability and eviction prevention and other kinds of services. And of course, you know about our public health services because we've been operating COVID testing, contact tracing, vaccinations, and we also work in every single school in Arlington County where we have a school health aide or a school health nurse working with the kids who are attending those schools. Next slide. So like the county's efforts in racial equity, we too, as the Department of Human Services, felt it was very important to shift our organization towards that mission. And we spent about 1.5 years really looking at our vision, mission, and values. You know that a vision and mission value statements is what drives an organization. And in our case, we wanted those statements to center race. Why? Because we know that racism is pervasive in all of the domains that we work on in Arlington, and particularly in the Department of Human Services, housing, education, financial stability, even behavioral health. You know that the outcomes for the BIPOC community are worse than for the white community. And this is why it's important to be race specific, but not race exclusive, because we know if we lead with race, we will also address the other disparities that exist along other lines of ability or gender or geography or sexual orientation. So our vision now that we are embarking upon is to create a just and equitable community that is healthy, safe, and economically secure, and free of systemic racism. Can we guarantee that this will happen? No, but we will work towards this vision, because that's what a vision is, what we want to see in this community. And our mission is to be in solidarity with Black, Indigenous, and people of color to create the equitable access to the resources and opportunities needed for every community member to be healthy, safe, and economically secure. And we know that those resources differ depending on what community member experiences. Next slide. We created these 5 value statements that we are committed to adhering to. 1, racial equity. We are going to try to intentionally remove structural and historical barriers for BIPOC people and provide the resources and supports that meet each person's unique circumstances and needs. And through this Marcus David Peters Act, we are also going to look at the specific unique circumstances of the individuals who come to our attention during crisis and provide those resources and supports. We want to make also through access that our customers receive equity-driven services with ease, choice, and dignity. It's not a shame to come to our department to receive services. We want to provide easier access to people where they feel that no matter what their circumstances are, they maintain their sense of dignity. Inclusion. DHS programs are stronger when they honor and recognize the diverse voices, cultures, and individuality in the community and department. And DHS responds to community and staff needs by building relationships, listening to lived experiences, and taking meaningful action to ensure equitable representation, participation, and decision-making. It is time for us to listen to the people with lived experiences. We can't say we know best because we are the people in these positions of power. We don't know best always. We have to listen to the people who are living the experiences and living the reality to know what people need. Authenticity has to do with understanding the values of the voices of our own staff and creating a work environment in which employees are supported, passionate about what they do, and empowered to be their authentic selves. That means all of the kinds of staff that we have should feel that they can be themselves, no matter their background or their disposition in life. Accountability, we will hold ourselves accountable, we will share information in a transparent manner, and we will collaboratively work towards outcomes that eliminate racial equities. Is this a tall order? Yes. Will it take a long time? Most likely. And we're not going to do it by tomorrow or even by next year. But we will work steadfastly towards this vision, mission, and values because this is what we have believed in. Thank you, Deborah.
Thank you, Anita. I do want to say that if you are writing notes, you can, not worry about it. We are going to send these slides to all of the registrants after this meeting, and we will provide a video link to this presentation as well. So you can just relax with that. And then we did get a question about Spanish language providers. Not sure what the question is. We work very, very hard to hire bilingual individuals. We have specific language pay positions in our department, but I can honestly tell you that there is a significant workforce shortage nationally, and very acutely in the area of behavioral health, where, as one example, 51% of all psychiatrists are within our retirement age in Virginia. So it's really a crunch time in terms of trying to find good people, and specifically people who are bilingual Spanish. So if you know of anybody, please send them our way. We are looking for them. We do have translation services, however, and we do make sure that individuals receive those services as they are needed. All right. Apparently my office light went out, but we will carry on. We are going to talk a little bit next about the Marcus Alert, the steps to our local implementation. The first step that is mandated by the Department of Behavioral Health is to form our local team. And I am really thrilled to tell you that we have a very intentionally selected, diverse group of 80 individuals, key stakeholders, who have formed our local team. And I'll tell you more about them in a little bit. These teams have conducted research and discovery. We have put together and organized a whole bunch of data information and shared that with our stakeholder group. The two subgroups are a mission group and a technical group. More on that in a minute. And we have, I think, something like 62 slides of information. So we're not going to be going into that detail this evening. But we will be publishing that as part of our local plan, and that will be posted on our website later this spring. And I'm looking forward to sharing that information because it's very illuminating. The next stage is, and these are not discrete stages necessarily, these are the steps that we must engage in and complete as part of the development of our local plan, and that is to gather community input. And you all this evening are a part of that community input. You'll have an opportunity, as I say, to express your views about options that are available to improve our services. And the stakeholder group will work towards looking at those options and identifying what our goals are as a community, what our current capacity is, what the gaps are, and what are the options that can fill those gaps. Now, I do want to caution everybody and help you understand that this is not a, initiative where we put together a plan and, check that box. This is going to be an ongoing effort in our community. And as I said, we have a very strong foundation with the work of the police practices group and have already worked towards achieving and implementing some of those, several of those recommendations in partnership with our police partners. And then there are other things going on at the state level and at the regional level that link to this initiative and that are a part of that initiative. Many of these projects are in process, not at completion. We have been stymied by the competition with our surrounding jurisdictions for clinical staff. Right now, our Department of Human Services has 100 vacancies out of 700 positions, and 50 of them are in behavioral health. At one point, a few months ago, we had over a 50% vacancy, actually it was almost 60% vacancy in our emergency services, which is a mandated and our most critical service. So we had to work towards really creative strategies to cover our shifts 24/7 and to recruit and retain our existing professionals. So it's not an easy process. It's very hard work, and it will be over a substantial period of time. It'll be an iterative process. As I said, we will be completing a local plan. It is currently due May 22nd to the Department of Behavioral Health and Developmental Services. However, I should note that General Assembly is currently in session, and there are a number of bills that are pending that relate to the Marcus David Peters Act. And one of the bills is to allow another year for the development of the local plan. That would take us to July 1 of 2023. And then there's other legislation that makes the Marcus Alert plan process optional for small communities, 40,000 and under. And I think that is because of the lack of resources in those areas where it's really hard to develop unique responses. And probably in those cases, there'll need to be a regional approach to ensuring that crisis needs are met. Okay, and then over time, after we develop our plan, we will work towards achieving that plan. That plan will likely include expanding our coverage for things like mobile crisis, which I'll talk more about, potentially adding a community care team, such as the Cahoots model, doing more outreach. We'll talk some more about some of the gaps and some of the options in just a bit. Next slide, please. So as I mentioned, we We did a very intentional and aggressive outreach to develop our stakeholder group to ensure that we had very strong representation of individuals with lived experience with behavioral health needs and having experienced crises and crisis response, good and bad, and family members. We have a wide range of professionals that touch on this area, we explicitly asked people their racial and ethnic identity so that we could have broad representation on the stakeholder group. The group is divided into a mission group, which is like our leadership group. That is, their role is to set the priorities, the timelines, to review the progress, to make recommendations to the county board and county manager with regard to the plan forward based on the technical group's recommendations. That group will approve the local plan for the Marcus Alert prior to its submission to the state. Our technical group are more experts on the ground, if you will, people who have the expertise and responsibility to take a look at our current behavioral health system and to give us feedback around the gaps and the strengths, but where are we missing the ball, and where do we need to shore up resources or develop new kinds of programs to meet needs. The technical group will be heavily engaged in gathering community input, which is our next phase, our engagement phase, following this evening and through the month of March. And they will use that information to make recommendations to hone in on the options for the going forward and drafting the Marcus Alert local plan, obviously in collaboration with staff. So here are some of the representatives that are on our Marcus Alert group. There's CSB members, there's local private providers, our emergency services teams are represented. Right now we do not have our crisis intervention team coordinator. That is one of our vacancies, but we are hoping to fill that soon because that individual plays a very important role with the Marcus Alert initiative. Law enforcement, not just our local police, but MWA, our sheriffs. We have multiple parties on the group representing law enforcement, social services, including both our adult and child serving protective agencies, rehabilitation and aging, fire and EMS, which is a very important partner in this initiative and have been really great to partner with around our crisis intervention center and giving us ideas about how we can do medical clearance in the future and willingness to partner with us in all kinds of ways. And our emergency communications center, which is a key partner in the Marcus Alert initiative, there is a mandate to implement a voluntary database. And the way this will work is that an individual or a family member could register themselves or their loved ones into this database so that if there's an emergency response really of any kind, the emergency responders will be able to see that that individual perhaps has autism and behavioral health challenges and may require a special approach. So I think that'll be very valuable. Our community has selected Rapid SOS, and they'll be marketing about how to enroll yourself or your loved one into that database in the coming months. But that is a part of what we're working on. Next slide. Key partner, the public schools. I don't have to tell anybody on this call that our children and youth are really suffering as a result of the pandemic, and needs have gotten very acute while resources are very limited. At the state level, there are only 12 beds available at the Commonwealth Care Center for youth across the state. So we have to rely on our private partners for psychiatric beds. Our justice system partners with whom we work on diversion and supporting individuals that come into the criminal justice system that have behavioral health challenges. Our county manager's office, we have 2 deputies involved on our stakeholder group. Behavioral health advocacy groups, including NAMI and our very own Arlington Mental Health and Disabilities Alliance, and the Disability Justice Coalition are represented on our stakeholder group. And then we have other stakeholders who are representing social determinants of health, representing other areas beyond behavioral health, because we know that those issues really impact persons who do have behavioral health issues. We just had a call today of an individual who was suicidal because he had a job interview. His ex-girlfriend was harassing him. His rent was due. And these are all pressures that really can crush somebody who is already experiencing a lot of stress and may have an underlying behavioral health issue. Advocates for racial justice and social justice, and as I mentioned before, individuals who've had lived experience either with behavioral health crises or law enforcement or both. Next slide. So what has this group been up to? We've had a number of meetings throughout the fall, and thank you all on this call who are stakeholders on the stakeholder groups for your time, your attention, and your input, which has been incredibly valuable. So we have conducted the research and discovery phase looking at a plethora of data with regard to Arlington, the demographics, crisis calls, CSB services for forensics, all kinds of aspects related to this initiative have been reviewed. To look at, are there any surprises? What does that mean in terms of needs and so on? The stakeholder group has done a lot of work, starting with values, I'll share with you in a moment, around drafting a vision and a mission. And Anita did a beautiful job of sharing the vision, mission, and values of the Department of Human Services. Well, the Marcus Alert stakeholder group has done a lot of work on the vision and mission, and we thought we would be able to share it with you this evening. We're like 95% there. They are very much rooted in racial equity, but it's an iterative process between the mission group and the technical group. And we want to ensure that we incorporate all of the input from all of the 80 individuals before we finalize and post those mission and values. So they will be ready very shortly. The stakeholder group has generated a list of opportunities to improve our crisis response system, and has done a lot of work on a survey that will be going out, I believe this week or next week, with regard to people's experiences, assessing people's experience with crisis and crisis response, their knowledge and understanding of our system, and where we should go with the system. All right, so we have a couple of questions with regard to Rapid SOS. How do you register for it? We will have a website in a slide coming up shortly, and that will show you how to register for it. I believe that the state still has to issue the guidelines for the voluntary database, what needs to be put in it or how it needs to be structured. So I believe it is still in process, but should be up and running this spring. And there's a follow-up question to that that has to do with REACH, which we'll talk about in a minute, which is a regional crisis response to individuals with developmental disabilities, mobile crisis response. And the question is, will REACH be working with Marcus Alert Systems to ensure REACH plans are accessible in the rapid SOS system with consent? And the answer to that is yes. The idea of the Marcus Alert is that the spider web of resources get interconnected in a more seamless way to support individuals. And that will be one aspect of it. As I say, it's complex and it's going to take some time to get there, but we are in the process of working on that. And then there's a question, can people tag license plates or frequent locations to their profiles in Rapid SOS? I believe that it is just tagged to your home. Those are some really great ideas, but I don't think we are there yet, and I don't know that there are plans for that at this time. But we can, it's tagged to the phone number. We can get the answers to your questions and make sure that they are included in our in the responses. Next slide. Okay, so these are the values that the 80 individuals in our stakeholder group that were the high frequency values that were identified in terms of the work. And just to give you a sense of the proportion, the compassion was the highest rated value at 32 individuals. Racial equity was the second value, 29 individuals. So compassion and racial equity were very, very close. And then dignity, 23, empathy, 14, respect, 13, accountability, 9, trauma-informed, and collaboration. Trauma-informed and collaboration were both at 6. These are all values that we are going to keep in front of us as we complete our work. Next slide. Okay, before we go to this slide, can we go back one? Let me just pause for a second and ask if there are any other questions that I should respond to at this moment in time. It's a lot of information. All right, we're going to go forward and we're going to pivot just a bit to talk about the Community Services Board. So the Community Services Board is actually a commission, a county board appointed commission of 18 citizen members, and it's an administrative policy board that oversees services that are related to behavioral health care across the lifespan and are licensed by the Department of those services are licensed by the Department of Behavioral Health and Developmental Services, and are funded actually primarily by the county. 63% of the funding is provided by Arlington County. 13% is provided by the state. There's a smaller amount, 6%, I believe, of federal funds, and then a very small amount of fees and Medicaid revenue. So with that being said, I just wanted to give you a very brief overview of what those services are, because while many of you on this call may be familiar with the CSB, as it's called for short, but many of you may not be. And I often hear from family members who say, I had no idea these services existed, and you don't even know how to find them, until the point comes when you need them. So I want to make sure that this information is out there. So they're comprehensive services, recovery-oriented, community-based, and they include our front door, our emergency services, which is 24/7, 365, including holidays. And as I said earlier, mandated, and we are always working to improve those services and bolster them. That group of individuals provides crisis de-escalation. They provide assessment of acute problems, and they work to evaluate whether or not somebody needs an emergency custody order to be evaluated over time, or a temporary detention order, meaning that they are a danger to themselves or others and need to go to a hospital for treatment involuntarily. Also, we have across the department same-day access to the initial intake or the initial assessment. And those services have pivoted to telehealth services, but are back to in-person services, sort of a hybrid. And we have found that the persons that we serve, many of them are very comfortable with telehealth services. Others absolutely must have in-person services. So we are working to provide both at this time. Our mental health services include a range of services, psychosocial rehab services, which are like a day program for individuals with serious and persistent mental illness, assertive community treatment, which is formerly known as PACT, now known as ACT, which provides very intensive services for about 110 individuals. And that is an evidence-based model that really is successful in keeping individuals out of the hospital. Individual and group counseling, case management services, contracted residential services. We have our justice-based services, our drug court, our behavioral health docket, which is about a year and a half old now. And I think we have 12 clients currently, pre and post plea. And that was a successful advocacy effort on the part of many of our key stakeholders to ensure that we had that in place and that it was pre and post. Jail diversion, jail-based programs, including both mental health and substance use treatment. And our forensic program for individuals who go to the hospital to be restored for competency. We have our TOW program, which is treatment on wheels that goes out into the community and really works to engage those individuals who are unhoused in our community, which is a very small number now relative to 10, 15 years ago. But they require some significant outreach and engagement. Employment services for individuals with any kind of behavioral health issue, and then a wide range of substance use treatment services. We have really been working in the last 5 years to expand our substance use treatment services to include office-based opioid treatment, and a number of interventions, peer outreach when an individual comes to our attention who's had an opioid overdose. There's a stakeholder group, Arlington Addiction. What does stand for? Recovery? I'm losing my mind right now. But anyway, Ari has done a lot of work in the community to set up medication boxes and to work with a wide variety of partners, bring together individuals to work towards addressing the opioid epidemic, which is now, thank you, Arlington Addiction and Recovery Initiative. Stumbled over that. The fatal overdoses, non-fatal overdoses, and fatal overdoses have really tripled since pre-pandemic. So it is grave concern to us, as well as the fatality of fentanyl, which has really invaded our community. So we're seeing more fentanyl now as opposed to heroin. So there's a variety of services. One I want to tell you about that we're very proud to have established in the last 6 months, which is the Recovery Center. We had a social detox program, and we ended our contract for that program, which was outmoded, and we developed a medical withdrawal program and a 90-day residential program. It's still in the same location, but it is not the old detox, and it is now fully utilized, I am pleased to say. The former social detox was not well utilized, and the Recovery Center is full, so that's good. And we are looking to expand our substance use treatment services. Okay, I think that I have a couple of questions here in the chat. Let me just see if I can read them. Okay. So there is a question about what privacy protections are in place for Rapid SOS. I don't know the answer to that. I am positive that will be a part of Rapid SOS, but I don't know the answer to that. So we will flag that as something to find out. And question, is there a way to add documents such as supported decision-making or psychiatric advance directive to a profile? And we will absolutely work with the state to see if that can happen. I think that's a really great idea. And a question, will stakeholder groups include disability self-advocacy groups? And the answer is yes, for sure. And to what extent does the plan involve training responders to respond to people with communication disabilities, for example, vision, speech, and hearing, including responders' ADA obligations to provide effective communication, auxiliary aids, and services under Title II? And I think that's an excellent question. The Marcus Alert Plan does not explicitly state the need to respond to individuals with communication disabilities. It refers to disabilities, but it doesn't explicitly state that. But that is something we can add to our plan to ensure that we address that. Then there's a question about the Marcus Alert, and I think this is a great question. Does Marcus Alert work across jurisdictions? That's an important question for me because we live in a tri-state area, DC and Maryland, and we are connected, we are contiguous to other jurisdictions in Northern Virginia. So the persons that we serve may come from those other jurisdictions. Anybody who's in crisis in Arlington, no matter where they're from, can be served by our emergency services. And so because of that, it's imperative that we coordinate closely with our neighbors to ensure that they get the services that they need when they return to their community, or make sure that they are linked to the services if they come here and they are unhoused. I know that we serve a number of individuals that come in through the airport in partnership with MWA and local police. And I know as one example that the individuals that we serve at the jail, 70% of them are not Arlingtonians. They're from DC and Maryland. So that's a very good question. The Marcus Alert will involve a regional call center, which will serve as a hub. And I will say more about that in a bit, but it will work across Northern Virginia. There is also a state database that is in development, and I believe that that will enable individuals who cross jurisdictions to be tracked, if you will. So those are very, very good questions. I didn't cover psychiatric services, but that's what that we have prescribers on staff, and we have a robust nursing staff to ensure primary care screening and medication administration. And we do a lot of work with our state hospitals around discharge planning. It's very important, particularly now, and I'm not sure if everybody is aware that the state hospital system closed to new admissions on July 9th because of staff vacancies and because about 5 individuals across the state staff were seriously injured every single day. They were, and then of course they would be offline to do work, and then COVID. And so it has really had a dramatic impact on the system of care, resulting in individuals boarding in the emergency department, sometimes for days. And we have been working night and day with our partners in the emergency department, our police partners, at every level, in all kinds of ways to address this crisis, including the state, and working with the commissioner and the Secretary of Health and Human Resources. Next slide, please. Go on. Okay, so this is a little bit of a complicated slide, but this is something that SAMHSA, the Center for Mental Health, the federal center, developed years ago, and it's a great way to sort of map out your community services where people with behavioral health crises come into contact and intersect with the criminal justice system. And the idea is to develop services at every point of intersection to support and support the individuals with behavioral health disorders and ensure that they get the treatment that they need. And this model has 6 intercepts, and it starts with 0, which is always a little confusing, but so you have to count the 0. So each intercept has a variety of services, and the Micas alert really is focused on intercepts 0 and 1. So intercept 0 on a crisis care continuum would refer to crisis lines, and we're going to be talking a little bit more about that shortly. And intercept 1 is where 911 gets involved. Someone calls 911 and law enforcement gets involved. So what we're going to do is work towards strengthening, connecting individuals to treatment without law enforcement involvement or a 911 referral. And then if they do intersect with law enforcement, to divert individuals to treatment as opposed to arrest or booking. Okay, next slide. So I'm going to run through what we currently have in our system of care at the intercept 0 and intercept 1, so that you have an understanding, and you might want to listen for, what are the gaps, or what might be your recommendations. As I mentioned earlier, we have a number of developments coming soon in the next 6 months, certainly in the next year, that will have a positive impact in filling some of the gaps. So we'll talk a little bit about that in a minute. So we have currently Crisis Link, and this has been around for a very long time now. We contract with Crisis Link They provide a hotline and a text line, which is very popular with our young people. And they have, I've toured their facility. They're a very impressive group. They're run by PRS, which is a local nonprofit, and they are highly professional. They train paraprofessionals, volunteers, and crisis line workers who staff it 24/7. And they do a great job of de-escalating individuals, doing suicide prevention, and linking people, doing like a warm handoff to resources that individuals need. They are very familiar with the local CSBs, community services boards, and their emergency services, and they frequently link individuals up that need those services. They know when to call law enforcement if it's like an absolute urgent need for intervention. And they also are aware of some of the other resources that I'll be telling you about in a second. Next slide. So, okay, I got my lights working. CR2, this is something that we worked on, I would say about 12 years ago. We identified, those of us in children's services, which is what I did at the time, identified a gap in the system of care for kids. We realized that we really needed mobile crisis services for children and young adults to support them and their families when an individual went into a behavioral health crisis. And we developed Children's Regional Crisis Response with a grant from the Department of Behavioral Health and Developmental Services, small grant. And we've grown it and grown it and grown it over the years. And we have just very recently expanded CR2 to provide mobile crisis services to adults as well as children and youth. So this is big. And we changed the name to Community Regional Crisis Response. We're still dubbing it CR2. And it's available by phone, by video conferencing, or in person. And you see the numbers on your screen. Again, you'll be getting these slides. It's operated by the National Counseling Group. It is managed by Arlington County. And we meet with them every single week to triage problems, to talk about the challenges, staffing being a big one, finding bilingual staff being another big one. But we've also expanded the time that the service is available. It used to be available during business hours. We then expanded it to the evening. We've now expanded it to be 24/7. And if responding in person, ideally that individual would receive the call within an hour. We have found that that is aspirational in Northern Virginia due to the traffic as well as other barriers. Oh, traffic and distance, it's a big region. This is a regional program, not specifically Arlington, but a regional program. So the number of individuals served it's very big. But we are growing it, we are strengthening it. And this is a critical piece of our Marcus Alert response. Somebody was asking, does it work across jurisdictions? Mobile crisis response is across jurisdictions, and this is a very significant piece of that Marcus Alert legislation. Next slide, please. So we also developed regionally the REACH program. And this is similar to CR2 in that it provides a mobile crisis response, but the target population is for individuals who are experiencing, who have an intellectual or developmental disability, such as autism, Down syndrome, etc., and they're experiencing a behavioral health emergency. This is something that we're very interested in addressing, which is the intersection of developmental disabilities and behavioral health crises. I think that that's an area where we need to grow and have more training in, and you know, we're aware of that. We brought in regional training. Actually, we asked the state to bring in a regional trainer. So we are moving forward in that, but we are still developing in that area. You see the contact information for REACH. It's operated by another nonprofit partner, Easter Seals. Again, it's staffed 24/7, 365, ideally response in an hour. The idea is, again, intervening in a crisis, de-escalating the crisis, because we know that if you provide mobile crisis services, that can prevent like 80% of the calls from ever needing hospitalization. Okay, next slide. Emergency services. Well, our emergency services, I'm going to call them intrepid. They are there during the snowstorm. They are there during COVID. We managed. We at one point we had 192 shifts unstaffed, and we put out a call for help. We got other clinical staff to provide support to ES. Never stopped. They provide assessment, crisis stabilization, intervention. They are the professionals who do the required assessment for really significant interventions, such as an emergency custody order, where somebody can be held for observation, and for temporary detention order, as I said, where somebody is a danger to themselves or others and needs hospitalization. Anybody can make a referral, anybody can walk in, anybody can call us, and we will respond. Let me tell you how many calls we get in a year, because I looked it up. We get over 38,000 calls in a year. We see over 1,600 individuals in person a year. We execute 576 temporary detention orders in a year. I can honestly tell you that the numbers have gone up. The acuity has gone up during the pandemic. And we are seeing, as we mentioned with the opioid crisis, we are seeing substantial increases in the numbers of individuals who are suicidal, and some really, really acute situations. Now, mind you, this is occurring at the same period of time in which we have a reduction of 274 state hospital beds as a result of the state hospital closing down admissions, new admissions. That's more than one hospital. That's a lot of beds missing. And so we have had to be very creative to identify ways to support individuals who really need that level of care. And we'll talk a little bit more about that in a second. Next slide. Crisis Intervention Center. I want to take a minute to talk about this, because this is a service that we have had, but we have recognized that it is insufficiently staffed. And so the Crisis Intervention Center is right here in Sequoia Plaza. It has 5 calming rooms. It has 5 new recliner beds that people can sleep in. They are lovely. We have enhanced security. We are licensed to provide 23-hour crisis stabilization. We can provide assessment. We can provide that crisis stabilization, peer support, that is an individual with lived experience, to provide that support and engagement and linkage to the services that they need. Can be any age, can be referred, and we operate that 24/7. But one of the things that we identified in collaboration with all of our partners and in many conversations with police, is that we need to have some kind of alternative to the emergency department for individuals who are waiting, either waiting for an assessment, waiting for medical clearance, waiting for a psychiatric bed. And so we realized that in order to achieve that alternative, we needed to have robust staffing. So the county board recognized this as well and authorized 4 dedicated positions for the Crisis Intervention Center in this fiscal year's budget. We have been working to fill those positions, and we have not been successful in filling them to date, although we do have a psych nurse coming on board soon. We realized that we need to have much more robust staffing and a manager and so on. So we have established a CIC manager position, brand new and permanently funded. And we have about 18 positions to staff our CIC 24/7 in the human resource process. So we hope to be recruiting for those positions soon. We hope to get robust staffing at our Crisis Intervention Center 24/7, 365, ideally by the end of this fiscal year, which would be June 30th. And there is a question about, can undocumented people use our services? And the answer is yes. You don't have to have insurance. You don't have to be a citizen. You just have to be in crisis, and we'll take care of you. Some of the other things that we are working on relative to the Crisis Intervention Center are to have it be a comfortable place where people can walk in if they're in crisis, and we had an individual do that just the other day, or a family member can bring a loved one in, or law enforcement could drop off an individual. So we would like to really report back on fully staffing the Crisis Intervention Center in the near future. And another piece that we are working on that I will share with you that is not in place yet, this is one of those things that's in development, at the recommendation of our police partners, we are looking at, we are actually working on a contract to hire individuals who would serve as special conservators of the peace. Special conservators of the peace. And these are individuals who would go through special training, about 40 hours, with the Department of Criminal Justice, and who would be appointed by the magistrate and the judge and the police chief, and would serve as a law enforcement officer in the sense of being able to provide, accept custody from law enforcement and provide alternative transportation to individuals in crisis. So what do I mean by all of that? These would be people who would be unarmed, who would provide, who would be able to accept custody from police, thereby reducing police involvement in this whole process, and be able to transport individuals when they need to go to a hospital or they have a temporary detention order and a hospital has been identified. So we're working on all of that, and we think that that will have a positive impact on, and they would be individuals who would not be wearing, police uniforms and not have guns and so on. So we think that that would be much more therapeutic for the persons we're serving, and would also get police officers out of guarding individuals in the emergency department, get them back on the street. So coming soon, but hopefully by the end of this fiscal year, we will have those individuals in place. And the other thing about the Crisis Intervention Center that I wanted to mention is that this serves as a place to go. So thinking back in terms of the Intercept model, you would have a crisis link is a place to call, and soon there'll be a regional crisis call hub. So someone to call, mobile crisis, someone to go to you, and then the CIC would be one prong in terms of a place to go other than the emergency department. Okay. And we have some transport questions that I will respond to now. Has considerations been made for transportation options for individuals to the CIC that is not driven by police, fire, EMS? Once we have gotten someone to agree to go for care, getting them there becomes a hurdle. I get that. Well, once we get the SCOPS contract in place, the special conservators of the peace, those individuals will be able to provide transportation. And again, they will not be in police uniforms, they will not be armed, but they will be able to provide transportation. So in a situation like that, and again, it's going to take us give us some time to get the contract resolved and find those individuals. They'll have to be trained. I mean, it's a whole process. They have to be, cleared and appointed and all that. But once we get that in place, that will be an option that will eliminate flashing lights and, further traumatizing individuals in crisis. I hope that answers your question. Okay, next slide. Crisis stabilization units. This is another aspect of Intercept 0/1, and this is another place to go. To get to a crisis stabilization unit, you do have to go through our emergency services. Right now, we have the Wellness Center, which is housed in Fairfax County. It's a lovely place, and you can go there for up to 14 days as an alternative to going to the hospital. And I am very excited to report some awesome news for our community and for the region. We have been working for 2 years on a regional crisis stabilization unit that is best practice, reflective of the Crisis Now model, which is the SAMHSA best practice model. The vendors RI International for Recovery International, and they just got approved for their license yesterday for a 16-bed residential crisis stabilization unit. So that's a lot of words. What does that mean? That means a place where people can go when they're in crisis and stay for up to 14 days. It will serve as a law enforcement drop-off entity facility, and it's housed in Chantilly, sort of central in the region, and it has space for an additional 16 recliner beds, meaning that it would be, we could build out another 16 beds for 23-hour crisis stabilization. But we don't have the funding for that. That would take another $4 million. So we're not there yet, but we're working towards that. So I'm very excited to report that's something, that's a success on the horizon. I am now going to pause and turn it over to Lieutenant Steve Troiano, who's going to talk about CIT.
Hi, good evening. My name is Steve Troiano. I am the police department's liaison to emergency mental health, and I am also the administrator for our crisis intervention training program. We established this back in 2008 CIT is an internationally recognized training program that is designed to teach officers to train first responders, not just police, in crisis de-escalation and active listening. It is unique. It is not just taught by police to police. It is designed to be coordinated and trained in partnership with our CSB. All of our officers attend a regional police academy. During that initial basic academy, there is an introductory block on CIT. It is a small introduction to a much larger topic. And then by design, after officers have completed their field training, usually about 6 months past that point, we have them attend a 40-hour CIT training class that's taught by persons who have lived mental health experience and also practitioners, and it's a very unique jointly presented training. Right now, our numbers are lower than we would like. We have not been able to keep up with training. Unfortunately, in 2020, COVID shut down all of our in-person training. We started to resume it in 2021, and then the county's CIT coordinator departed for another position, and his replacement has not been identified yet. Once they are, we're gonna have a lot of work for them. But each successive academy class we graduate, unfortunately, statistically pushes us further down. So currently we are at 73% of our patrol division and 53% overall. We historically have offered this both to the Arlington Sheriff's Office in about a 50-50 partnership, but we have also included the Arlington County Fire Department, Metro Washington Airports Authority, and the Emergency Communications Center staff as well have all participated in training. In addition to CIT, in 2021, we began a multi-year de-escalation training program where officers attend a quarterly virtual training class for 4 hours every quarter. I believe that's a 5-year training program that we have committed to. And then beyond that, in the planning and future stages, we do intend to add advanced CIT and refresher CIT trainings. Right now, we're going to be a little focused on catching up our backlog of officers for the main 40-hour class, but that is definitely something we look forward to including in the future. And that's the whole slide. So I'll turn it back over to Deborah.
Thank you so much, Steve. I really appreciate it, and I really appreciate your partnership and that of Captain Mike Rowling and Deputy Wayne Vincent and Chief Penn. You guys are working with us every single day and meeting with us regularly to figure out how we can really improve our collaboration and make things better for people in crisis. So thank you very much. It's really hard work. We're all short-staffed, and we just really appreciate your responsiveness and also all of the improvements as a result of the police practices group and the Hillary Heinz recommendation. So thank you. Appreciate it a lot. Next slide. Okay, so coming soon. So I did already sort of share with you in my excitement about the RI International Regional Crisis Stabilization Unit, 16 additional beds. What's not on here on this slide that we should have put on this slide is we have been working collaboratively with another stakeholder group, including CSB members, former CSB members, advocates, persons with lived experience, with the Virginia Hospital Center to expand, to make a number of behavioral health improvements, including expanding the number of beds of the behavioral health unit. And I am pleased to report that we received this week the written certificate of public need for 16 additional behavioral health beds. This is the culmination of about 7 years of collaboration, and we're very excited about it. Those psychiatric beds will be mostly private beds. They will just about double the number of beds at the Virginia Hospital Center. And the Virginia Hospital Center and the stakeholder group are working very closely around, in fact, we're meeting tomorrow morning, around the design of that behavioral health unit. The old unit will be totally gutted, and it'll be basically 2 floors connected, and it'll be beautiful. And lots of natural light and an outdoor space, and lots of recommendations are being acted on there. Also, we are working with the Virginia Hospital Center on the development of an intensive outpatient program for persons to step down after being on a behavioral health unit, or as an alternative to going to the behavioral health unit. So that also is in development, more than a twinkle in our eye. We have a written proposal from the hospital, and we are working with them on changes to the emergency department when they do the renovations to the emergency department, to have an allocated space specifically designed for persons in behavioral health crisis and their families, so that they can have some private space. You know, being in the emergency department for anybody is not therapeutic. It's traumatizing, right? And if you're already in a behavioral health crisis, it's just further exacerbates the stress that you're under. So particularly if you're there for long periods of time. So very excited to report some real positive changes coming soon, specifically to the Arlington community, to expand our behavioral health resources. We just have to find the people to staff these. Anyway, there was a question about the voluntary database, and you'll see there emergencyprofile.org. We will work with our emergency call center partners to roll out communication as we get further down the pike with this development. But I think it's really going to be helpful to family members. And then, okay, so the next exciting thing to tell you about that we've been working on now for 2 years is the development of a regional crisis call center. And this will be our crisis hub for the region. And if you think of like a spider web, you know, this will be the center of the spider web, and it will connect to all the emergency call centers in the region. So it'll be easy, and all the emergency services and all of the mobile crisis providers. So people can call, and it will replace Crisis Link and provide all of those services, de-escalation on the phone. There'll be a text, chat line, and there'll be live human beings who will answer the phones and who will not just de-escalate, but triage the situation according to level of urgency. Like the state has a framework of 4 levels of urgency. And, a level 1 might be just, resolution just by talking to the individual, phone de-escalation. And that's really almost 80% of those calls. The next level would be to have behavioral health response only, to send out mobile crisis providers. And then the next level would be more of a co-response model where you send out behavioral health and law enforcement to ensure safety. And then the last level would be law enforcement. So these individuals will be trained in how to triage those calls and how to connect them to the right services. And they will serve as the hub to dispatch those mobile crisis services, if that makes sense. It's in development. We just signed a contract with PRS. the providers of CrisisLink, who will develop that regional crisis call center. They're under a tight timeline because 988, which is established with federal legislation, will be rolling out in July 16th. And that will be the National Mental Health Crisis and Suicide Prevention Hotline. So our hub for 988 will be the Regional Crisis Call Center. And so it'll be a local center. Those calls will be routed to the local center, and there'll be GPS, technology, so they'll know where the calls are coming from and so on. And there'll be all kinds of federal and state marketing of 988, so that ultimately, hopefully by the end of 2022, everybody will know if it's a behavioral health crisis, you can call stigma-free 988 as opposed to calling 911. It's really exciting. Actually, the person who is actually managing the 988 rollout implementation is Dr. John Palmieri, who was our previous behavioral health division director. So while we miss him, he's doing really important work at the national level. Well, no. Okay, next slide. Okay, so opportunities. So there are lots of opportunities in the hopper. There are a lot of ideas out there. There are lots of models that are popping up all over the country. We are interested in hearing your thoughts about what direction we should take next. As I say, there's a number of things in development. And actually, this first bullet here is in fact in development. So maybe you shouldn't have put that there. But so one of the things that's been discussed in a lot of communities and established in a number of communities is the idea of a community care team, which would go out in a van or whatever, and it could be a behavioral health professional with a person with lived experience, a peer who would work with that professional to engage the individual who might not be interested or understand that they even need services, to work with them, to engage them, and to provide supports that they need that might be non-clinical, like shelter or bottle of water or whatever. So that's one concept that's out there. Next slide. Outreach and engagement, to have much more prevention, early intervention, community education, and outreach. Another thought is we did do an experiment. We had a pilot where we had a clinician at the emergency call center, and that was really useful in terms of providing consultation around which calls should be routed to our emergency services for response, and de-escalating callers on the 911 line. So that's another possibility. You would need to do that 24/7 though. It can't just be during business hours. So so that's something we could take a look at. Another idea that has been floated is the idea of a regional crisis receiving center. So it would be a little bit more expanded than that RI International that I mentioned, even if it had the 16-hour, 23-hour, 16-bed, 23-hour crisis stabilization, plus the up to 14 days residential. This would be more of like an emergency department, but focused on psychiatry, where you'd have prescribers available 24/7, nursing staff to do medical clearance and so on, and to really, fill a gap and really take people out of the emergency departments of our hospitals, which are really drowning in psychiatric emergencies. Other things that have come up through our stakeholder group, Marcus Alert stakeholder group, are expanded substance use services, particularly for minors. There's a dearth of services. Certainly there's no residential services, detox services for minors in our community, and creating more sober living type communities, sober living homes and communities. Next slide. Something else that has surfaced through various advocacy points are having a peer or a staff navigator who would help individuals and their families post-discharge from the hospital, the jail, or the crisis system to help them connect to available services. As I said at the beginning of our town hall, a lot of individuals don't know where to go. They don't know how to get the help that they need, and they don't know, you know, once their loved one is in crisis, they don't know where to go next, and it's just a maze to figure out. So a navigator would be an individual who could help people, help individuals, but also their family members, you know, with navigating those services. And then there's the idea of restorative support circles for individuals who've, you know, had an experience and been harmed, and to figure out what are their needs, what are the resources, and how those needs can be met in collaboration and with the support of their friends, their families, their, you know, whoever is a support to them. And then finally, one issue that has come up repeatedly is supporting individuals who have loved ones who are really, really ill, really, really need treatment, probably need meds over objection, and are resistant, or their illness interferes with their ability to understand their need for services. So those are some of the ideas that have come up through our stakeholder group. And I just wanted to pause for a second before we go. We are going to do some voting on options, but I wanted to pause to see if we have any questions from the team or from the community. No. Okay. We are going to go now to do some voting. Okay, so the directions are, you can choose up to any 5 of these new initiatives. Now, to do this, it's really fun. It's much easier than I thought it would be. You can use your camera on your phone, and you can use your camera and focus it on the, what's that word called? Can't remember what that
QR code.
QR code. Thank you, Anita. My brain is dead. Okay, so you focus it on the UR code, and it will take you right to, you'll see a yellow thing, and it will take you right to slido.com, and it'll take you right to this poll, okay? Or you can go to the website, slido.com, and enter 540351, okay? So you have 2 choices. You can scan the QR code with your phone, like just like that, and tap on the yellow. And it'll take you right to, and we're getting responses already. It's exciting.
Deborah,
Yes,
does everyone know what each of these things means? Like,
I just explained it.
okay, good.
Yeah.
Terrific.
I just went through all that.
All right, folks, get in your votes. Come on, people. We're looking for that voting and for those lines to go green.
Why don't we give people a few minutes just to navigate and then select their options. So it's 8:09. So shall we give people about 4 minutes?
Absolutely.
Okay.
I don't think people can really hear me on this because I'm not live, but.
All right, we're gonna give it one more minute. So while you're wrapping up your selections, I wanted to just share there is a question. Will there be an opportunity to send our suggestions regarding identified gaps and possible solutions after this evening? And the answer is absolutely. We are going to be sending out that survey that I mentioned. We'll make sure that you all receive that survey, and there'll be 3 focus groups. We also have a web address, and it'll be at the end of your presentation, but it's pretty easy to remember. It's Marcus Alert, one word, at arlingtonva.us. So I have a question. When we send this presentation out, will we be able to show the outcome of this poll in the presentation?
We can.
We can? Okay, great. Good. All right. Thank you all so much for taking the time to do this. We really appreciate it. We need the feedback, and we thought this might be a good way to do it with 140 people. So thank you. All right. Next steps. So we're just going to kind of let you know there's a lot more work to be done. As I say, this is the beginning of a multi-year initiative. It's not just developing the plan and submitting it. It's all of the work involved, and there are multiple layers. One of the layers is developing Marcus Alert protocols. They are explicit in the legislation. And one protocol is, how will we transfer our calls from 911, from our public safety access point, the emergency call center, to this 988? Okay, so we got to work that out. And as I say, we are just working on the development of the regional call center, so this is going to take us a few months to get that done. The second protocol is an agreement between that mobile crisis call center / hub and local law enforcement. So it's not just the matter of the Arlington Police, it's MWA, it's the Sheriff's Department, it's 5 jurisdictions and multiple law enforcement agencies. So it's a very heavy lift. And we have already started that work of drafting that agreement. And then the third protocol has to do with a specialized response for law enforcement when responding to a behavioral health emergency. So all of this is going to take several months to really work through. But I have confidence. I feel like we're well on our way. Next slide, please. So next steps for our community, we are going to be sending out this survey very shortly. You'll see it in your inbox within a week, and it'll be out until mid-March. And we'll be conducting, we've hired a contractor to conduct 3 focus groups. And then we'll be working on our local plan with our stakeholder group. And it will be published. Everything will be transparent. The protocols will be transparent. The outcome of the surveys, we'll post that, outcome of the focus groups, and so on. So I believe that is all I have for this evening. I know it was a lot of information, and it's hard to listen for a long period of time, but we will send you the PowerPoint in case you missed anything. And if you are interested in being further engaged in this work, we'd be delighted to have you participate in the survey and or a focus group. And there is our email address on your screen, marcusalert@arlingtonva.us. So I think I'm going to pause and see if there are any questions. Any further questions at this point? Okay, no further questions in the chat. Let me ask my colleagues if they have any closing remarks that they would like to make. Anita? Steve? Okay. So I think that we are really at a good point to close. I want to thank you all for your time and your energy and attention and commitment to this really important work. Our goal is to reduce the stigma of getting help. Our goal is to have resources to ensure that help is available. Our goal is to implement the Marcus Alert in the full spirit in which it was developed and legislated. And we're going to be doing that regardless of any kind of legislation that delays it. We are going to continue going forward. And we also are really open to your feedback. So if you want to send us an email at marcusalert@arlingtonva.us, please feel comfortable doing that anytime. And we will get back to you. We'll send you the slides. And again, thank you and have a good rest of your evening. Take good care now.